Hi, so today we're here with Dr. Rocky Patel, primary care provider and Phoenix Market Medical Director for One Medical. Hi, how are you doing today?
Good. How are you doing?
I'm
Nice to
doing
see you.
well. Wonderful. Thank you so much for being here and dedicating this time to go over some of the questions that our patients typically have. Today, we're here to hear you speak a little bit about diabetes and different types of diabetes and what routine labs that patients should look into. So if you'd like to just jump right in and get started, I'd appreciate it.
Sure. I mean, I think when we think about diabetes, there are two major categories that most patients are probably aware of. There's type 1 diabetes, which is basically a disease of a lack of insulin. And that's usually caused by an autoimmune reaction. This type 1 diabetes used to be called like insulin dependent or juvenile diabetes, but it can actually occur at any age. And typically, the pancreas is making very small amounts of insulin or none whatsoever. And so patients will require insulin for treatment. And with type 1, we don't necessarily have like the true cause, but certainly risk factors like family history is an important risk factor for developing type 1 diabetes. And typically, like I said, usually we see it, the onset usually in like childhood, teens, young adults, but we can see it happening in older individuals as well. And then I think the bigger category of patients that we see are patients who have type 2 diabetes. And type 2 diabetes is a disease of what we call insulin resistance. That means that the body is not hearing the signaling that the insulin is trying to give the body. And so what happens is the pancreas then makes extra insulin, try to make the processes work in the body. And so over time, the pancreas, as I described in patients, will eventually poop out and will start making less amounts of insulin. And then those patients can eventually require insulin for their therapy and their treatment. And typically, like if you look at risk factors for type 2 diabetes, pre-diabetes obviously is going to be a risk factor. Insulin resistance actually is a condition that can start very early in life, even nowadays in teen years. And we don't really have an idea of how many pre-diabetic patients will actually progress to diabetes, because there's a subset of population of patients who have pre-diabetes, but they don't progress. Certainly other risk factors include carrying extra body fat, especially around the abdomen, being 45 and older, family history of type 2 diabetes, not being physically active. Like if you're not doing any type of physical activity, less than 3 times a week, that's going to be a risk factor as well. We know that in women who have gestational diabetes during their pregnancy, they can also be at risk for developing type 2 diabetes through their lifetime. And then we also know there are some ethnic variations that can also put you at risk in terms of patients who are of African American descent, Hispanic descent, and Asian Americans as well, and Pacific Islanders. So those are some categories that may be at higher risk as well.
Gotcha. And what is the onset of like type 1 diabetes versus type 2 diabetes? What do you typically see within your practice and gestational diabetes? What is the percentage of women that you notice that have that develop into type 2 diabetes?
Yeah, so if we look at like onset, as I described, typically type 1 patients, we will usually present, they can either present in a couple different ways, because type 1 diabetics can sometimes still have small amounts of insulin. And so they might have slower presentation of elevated sugars. There are those who are type 1 that will present what we call diabetic ketoacidosis. So typically what will happen is they'll have an infection or have trauma, and that spurs on a significant amount of uncontrolled sugar. They end up in the hospital, and then it's discovered that they actually have type 1 diabetes. And then with type 1 diabetics as well, often once they're first diagnosed, there can often be like a honeymoon period after diagnosis. So they get diagnosed with type 1 diabetes, their sugars are quite high, sugars come under control, but then they don't require insulin for a period of time. and then the sugars kind of climb back again. We call that a honeymoon period. That can sometimes occur. With type 2 diabetes, we know that patients have typically have this metabolic issue of insulin resistance for at least 5 to 20 years before their diagnosis. And with type 2 diabetes, typically the dysregulation or the elevation in blood sugar typically occurs after you eat. And so historically, when patients go to their doctor to see their physician, they're always getting their labs drawn fasting. And typically in type 2 diabetes patients, the fasting blood sugar is usually the last domino to fall. So they could actually have diabetes long before it's discovered that their after meal sugars are high because they're just not catching it, right? So in what I've instituted in my practice typically is I don't require fasting for labs because it's almost another way of looking under the hood. If you come in after a meal, then I'm going to actually have a better idea of how you are metabolically and how you're handling the meals. So that's something that I think is super important to kind of keep in mind. Certainly, it's nice to have it historically the same state of fasting or non-fasting as you go through to compare numbers serially, but I think it's important to know that that you could potentially miss the diagnosis of type 2 diabetes early on. So I think that's super important. And I think that we all, you had mentioned lab tests. We know that certainly there are a couple of different ways you can screen for type 2 diabetes. Number one, there's a blood test called the hemoglobin A1C. This is a 90-day marker of how your sugars have been. And typically what it does is it's counting like the sugar coating on a red blood cell, and the life of a red blood cell is about 90 to 120 days. So we can measure that sugar coating. The percentage that would get you the diagnosis of type 2 diabetes would be 6.5% or higher. If that number is at 5.7% to 6.4%, we would call that prediabetes or increased risk of becoming diabetic in the future. And then a level of 5.6% or lower would be in the normal range. But as I mentioned, there are a lot of patients that could have a pre-diabetic A1C and actually technically have diabetes, because the other way you can determine type 2 diabetes is by doing an oral glucose tolerance test. And so a fasting sugar of 126 or higher is diagnostic of type 2 diabetes. And then a 2-hour sugar after a glucose load over 200 is also diagnostic of type 2 diabetes. So, if you get someone who's in the pre-diabetic state, they could have an A1C of 5.9 and a fasting blood sugar of 110. So clearly those are in the pre-diabetic range. But if you give them the oral glucose tolerance test, they could have a 2-hour sugar that's way above 200. So that's where you might miss patients early on.
Correct. So you mentioned something about the honeymoon phase for patients who have type 1 diabetes, and that their blood sugars will be normal. In that phase, is there a treatment required? Do patients typically go without any treatment, or they just put them on something just to kind of equalize the blood sugar throughout?
Yeah, I think it's just predicated on their blood sugar during that honeymoon phase, and it can be variable, right? They might not need any insulin during that time, or they might need small amounts. So it's going to be individualized in terms of how that looks for that patient.
Gotcha. So, and then going back to that hemoglobin A1C, is that a routine blood test that is done for everyone, or is this something that when you go to the doctor, you have to ask for that to be checked?
It typically depends on your provider. There are screening recommendations provided by the United States Preventive Health Task Force, but in general, most providers include an A1C on their lab panel. It's also like if you go for life insurance or disability insurance and they had to come out to your house and they draw your blood, typically they're checking an A1C on that as well. So if you don't have a regular provider you see on an ongoing basis, but you went for like an insurance policy check or increase your value, then you can actually ask for those labs. They should provide you a copy of those labs, and you should get a blood glucose value, either an A1C or a blood glucose on those tests as well.
Gotcha. I know I asked a lot of questions at the same time. So what percentage of women that get diagnosed with gestational diabetes do you see that kind of convert into type 2 diabetes?
Well, I'm a family practitioner, so I don't necessarily see, I don't take care of pregnant women. Um, but that percentage can be, let me just double check here and I can typically can be like somewhere in the neighborhood of like less than 10%.
Gotcha.
Yeah.
So what do you, again, I know you don't take care of pregnant women, but what do you recommend typically for patients who are pregnant and have been diagnosed with gestational diabetes, what to do to kind of reduce the risk of converting to type 2 diabetes?
I think that once your pregnancy is complete, we're gonna talk about the same lifestyle management issues that we talk about other patients at risk of prediabetes. So making sure they're following a high fiber diet, making sure that they're getting adequate physical activity, and trying to maintain a normal body weight. Those are typically the three things that we'll continue to espouse for anybody at risk for type 2 diabetes.
Gotcha. Wonderful. Thank you so much for that. And patients that are that have gestational diabetes, what sort of treatment do they typically get placed on while pregnant?
Yeah, so usually women who become pregnant typically will get an oral glucose tolerance test from their obstetrician, and if they essentially fail the test and they have gestational diabetes, either their obstetrician will treat their sugar, or typically they get referred to a maternal fetal medicine specialist who will then help manage the diabetes. Typically, insulin can be used for that treatment if needed, and depending on how severe the sugars are.
Gotcha. Wonderful. Thank you so much for that. So, can you maybe go through some of the typical medications that you see or our patients would like to be more familiar with, um, as someone who is newly diagnosed with, let's say, type 2 diabetes? Because we know type 1 diabetes is mostly insulin based, but for someone who has type 2 diabetes, what are some of the medications we see um, early on, and then what does it progress to?
Sure. I mean, I think currently we're in a really exciting time for the treatment of type 2 diabetes with some of the newer medications that are available to us. I think that I always like to think of the pathophysiology or the root causes of type 2 diabetes when we use medication. There is a kind of a algorithm, they call that ominous octet. This is labeled by a diabetologist in Texas. And the octet are the 8 causes of why sugars are high. And so we can use medications to address each one of those issues that occur. Also, the American Diabetic Association and the American College of Endocrinology have issued guidelines as well in terms of what medicines to use and when. So it's important that providers look at those guidelines and are consistent with that too, because that's been vetted. But typically, we're always going to have a foundation of lifestyle change, right? So before we even talk about medication, we want patients to follow a diet that's high in protein, that is removing processed foods, and making sure that they're getting adequate physical activity. And when we say adequate physical activity, I mean, I think people think about like going to Orange Theory and 5 times a week and killing themselves. And really, that's not what we're saying. What we're saying is that we want patients to have about 150 minutes of activity a day. And that activity could be a brisk walk or a bicycle ride. I mean, that's all that takes. And I think
Yeah, it could
so.
be just doing things around the house or gardening,
Exactly.
things like
Yard
that,
work,
correct?
that all counts. So we want to make sure we're talking about that foundational lifestyle, therapeutic activity, things that we can advocate for. Then typically the first drug that we would use is a drug called metformin. This helps address one of the issues of the liver making too much sugar. And then from there, it just depends on the patient's individual medical condition in terms of what we would use. Typically, there are a group of medications called an SGLT2 inhibitor. This is an oral tablet, again, that can be taken once a day, helps patients get rid of sugar through their urine, so they actually pee the sugar out. Patients who have heart disease, who have heart failure, there have been studies have shown that they get extra protection from these medications. So that might be a next add-on that we would use. there's a class of medication called GLP-1 receptor antagonists. And so these are actually injectable medicines that are not insulin that can be dosed daily or weekly. And again, these are medications that actually have cardiovascular benefit as well. So if someone has heart disease, this is something that maybe we would recommend in addition to the metformin. And then we also have some medications called sulfonylureas. This is an oral tablet. Just basically kind of like whips the pancreas to make more insulin to lower blood sugar. One of the side effects with that medication can be low sugar reactions or hypoglycemia. So these medicines, although they're generic and inexpensive, have kind of fallen toward the lower end of the algorithm for using medications. We also have glitazone medications. There's only one on the market called pioglitazone. This is marketed as Actos, and this helps sensitize the body to insulin. And so, and then we have one last class of medication. It's actually called bromocriptine, or Cyclacid is the brand name. It's the only one in its class on the market. Not very many practitioners use this medication, but there is part of the ominous octet is dysfunction of neurotransmitters in the brain, and the Cyclacid helps address that core defect of type 2 diabetes. And then obviously we have insulin as well. So we have long-acting and short-acting insulin. And so certainly there is a time and place for all of these medications. And typically by current guidelines, when you get diagnosed with diabetes, depending on what your starting hemoglobin A1C is, would dictate like what we would recommend and how many medications you'd recommend and which ones. So the higher the A1C at diagnosis, the more likelihood we would start maybe 2 or 3 medications or insulin right out of the gate, versus someone who has a lower A1C. Let's say they come back and their A1C is 7.2%. Maybe we're going to work on just diet and lifestyle for 3 months, or diet and lifestyle with metformin.
Wonderful. There's a cutoff for starting insulin right off the bat for patients with type 2 diabetes when they just find out. What is that cutoff?
So there's actually no cutoff for use of insulin. I think the question here becomes is why we would use insulin at the time of diagnosis. And so when patients come to us and they have type 2 diabetes and their A1C is very high, usually greater than 9%, often we'll see patients coming in like with 11, 12, 13, even 14%. There is a role to use insulin in those patients initially up front, because often what could be happening at the pancreas is because the sugars are so high, the pancreas isn't making a lot of insulin initially, and you kind of have to give that pancreas a bit of a rest. And so you can use insulin in a short-term fashion, get those sugars down under control, and then potentially then potentially get those patients over to other medications in transition.
Wonderful. Thank you so much for that. I mean, the topic of diabetes is so huge that we can't cover it all in one session, but just kind of give an overview of diabetes. And then obviously our patients can send in questions and I will relay those questions to you and we can answer them. But I wanted to talk about a really controversial hot topic that we are facing today is these weight loss injectable medications that are typically diabetes medication, and everyone's using them for weight loss. Some of them are FDA approved for weight loss. What do you think of them? Any pointers, any suggestions? Do you approve? Do you not approve? How do you feel about them?
Yeah, I think you're pointing toward these GLP-1 receptor and agonist medications are injectable. They've been out since the late 2000s, 2010 period of time. The first one that came to market was a medicine called exenatide. The brand name was Byetta, and it was a twice-a-day injectable drug. And then after that, we saw several drugs coming forth, and more recently we have semaglutide and tirzepatide as well. And so these medicines have been on the market for at least 15 years. And what we saw in diabetic patients early on is it was great with helping them lose weight. And obviously the drug companies saw this. And so they went and did more studies to expand the labeling of these medications. So the first medication that got approved for weight loss was liraglutide. It was labeled, it was indicated for diabetes under the name Victoza. And then after they went back and studied it for weight loss, it was marketed as Saxenda for weight loss. And the difference here is, yes, the medicine is the same, but the dosing is different. So typically, for example, for Saxenda, the dosing for weight loss is at a higher dose than what you use for diabetes. And then we saw this kind of gap in over time. And then semaglutide got approved from the FDA. That got labeled, or it got marketed as Ozempic for diabetes. And again, we saw great strides in helping patients lower their blood sugar, improve their health, and lose weight. And so that went back through trials again and got approved as Wegovy. And so Wegovy, again, it's indicated for weight loss, but the dosing is higher than what you use for diabetes. You know, when we think about obesity and people struggling with weight, it is a multifactorial cause. This is not one thing. It's not that just because people are eating too much food or people are not exercising enough. There is a physiology that's causing this defect, and it starts at the level of the brain. And once you have this dysregulation at the level of the brain, it's really, really hard to turn off. And so I think these medications can be used as a tool to help patients who are struggling with their weight. And they're quite remarkable, and they work very well for patients who can tolerate them. Certainly, any medication can have side effects, but for the majority of my patients that I use these medicines for diabetes or weight loss, it's usually tolerated well and can really make a big difference in getting them to the point where they can turn their lives around. Now, the real question here is, how long do you stay on these medications? Because if there is a hormonal issue going on, that's a signaling issue with patients who struggle with their weight, what happens when you stop the medication, right? And we don't have the answer to that question yet. I think obesity experts are trying to figure that out. But I think you probably have seen news reports of patients who go on the medicine, they lose weight, they go off the medication, and they regain the weight again. So I think among obesity experts, I think we think that dysregulation of the hormonal milieu of patients who struggle with weight, probably my guess is that in the long run, they'll need to be on some level of medication long term, but those studies haven't been done, and we don't have any expert guidance so far. I think they're a great tool. It's not it's something that we would want to use in addition to lifestyle, though, right? We want to make sure that we're doing all the lifestyle things first.
And obviously, if you get off of it, continue with that lifestyle modification. Correct. And stay on top of your health. Well, thank you so much. This has been very informative, and I hope our patients send us questions and we can answer their questions. I really appreciate your time and for all the great information, and I hope you have a great day.
Thank you. Have a good one.
Thank you. You as well.